So good afternoon, everybody. We're about to start our webinars, Postnatal Care in a Pandemic webinar series. So this is the second webinar, Early Well Baby Follow-Up Care. So I'm very pleased to be having this webinar today with you all. The objectives that we promoted was to increase awareness about available well baby follow-up in the region, to describe features of innovative postnatal well baby follow-up initiatives, and to identify tips and tricks for providing well baby follow-up in a pandemic. So I think a lot of people are familiar with CMNRP, but I just wanted to mention that the Champlain Maternal Newborn Regional Program is a regional integrated network, and we work together to ensure that families can achieve the very best outcomes during their pregnancy, birth, and postnatal times. And so CMNRP is a network, and we provide leadership and support and coordination for the planning and delivery of services in the Champlain and Southeast region. And so we do that actually in working with partnership with many partners and many stakeholders. So our partners are hospitals and public health, community health centers, midwifery practices, academic institutions, community agencies, and most importantly, families. So it's working together to make sure that we can support the very best health system for our families. And so, what we're talking about in this webinar series is an example of how we've come together to look at an issue that was really important. Early in the pandemic, it was identified that families after birth were having difficulties getting the follow-up care that they required. And we heard that from families, and we heard that from healthcare providers. So we were asked to form a rapid response task force to look at this issue. And I want to thank and acknowledge Dr. Daisy Moores, who was co-leading this task force with me back in the spring. And we've listed the members of the task force, and we definitely appreciate all their time and their efforts. So this was a lot of work in late spring and throughout the summer to really understand this issue. So in previous webinars, I talked in detail about our strategy for collecting the information. So I'm not going to repeat that today, just to maximize the time that we have for the panelists. But we do encourage you to look back at previous webinars to learn more information about how we collected information about this. The most important thing to tell you is that the three top priority concerns were related to breastfeeding, to mental health, and newborn follow-up. And that's how we've selected the topics for this webinar series. And this is the last webinar in the series about newborn follow-up. So we have an amazing lineup of panelists again. So we have Dr. David Miller, who I think is well known to many of you. He's a family physician who trained in family medicine and ran a family practice for over 20 years. Over time, Dr. Miller focused his practice and now exclusively provides newborn care as well as low-risk obstetrics at the Ottawa Hospital Civic Campus. He's also an assistant professor at the University of Ottawa, Faculty of Medicine. Combining his strong advocacy for primary-based maternal and newborn care and his vision for improving linkages between institutional and community-based care, Dr. Miller was instrumental in developing the Monarch Center concept in 2013. So since that time, he's been the executive director and medical lead at Monarch. And presenting on Monarch is Tara Parsons, who's a registered nurse and an international board certified lactation consultant. Her nursing experience includes nursing in labor and delivery, maternal newborn care, and gynecology. She also worked for many years as a public health nurse in the Healthy Baby, Healthy Children program as a public health nurse with Ottawa Public Health. And she's been the director of patient care since 2014 at Monarch. She's created and developed and leads the parenting and breastfeeding classes. So, Tara and Dr. Miller.
Thank you.
Thank you. So we are the Monarch Center for Maternal and Newborn Care. You can change the slide there, Christina. And our goals for you today is to present what exactly is the Monarch Center, who do we serve, what does the Monarch Center do for mothers and babies, and how did our services change with the pandemic? So we are a community-based transitional care clinic. We are multidisciplinary. We have 10 physicians, 12 nurses, and 6 care coordinators who work with us 6 days a week. We manage the transitions to and from the hospital, specifically the Ottawa Hospital and more recently the Children's Hospital of Eastern Ontario, CHEO. We also receive community referrals and from family physicians and midwives and have other institutional partners. So we work with Ottawa Public Health, OSNI with families from Nunavut that come here to have their babies, Children's Aid Society, and Newborn Screening Ontario. We do provide newborn screening with the newborn screen program as well as the CCHD, which is the heart screening. And we have had partnership as well with the hearing screen program in the past and currently. So we currently have 2 locations and are open 6 days a week. So our West Ottawa location is our original location in Nepean, near Merivale and Hunt Club, and it is open 6 days a week from Monday to Saturday. And then we have our Southeast Ottawa Center near Billingsbridge Mall. So that's the Southeast Bank Street area of Ottawa, which we expanded a little bit more accessible for public transit and to help better serve the eastern areas of Ottawa. It is a program that's covered by OHIP. So it's billed directly to OHIP, and we do, of course, provide prenatal education for breastfeeding and the first weeks of parenting. So it started off as an in-person prenatal class. It became more and more popular, and we introduced it via Zoom at the last few years. And now, of course, with the pandemic, it's done strictly online virtually. Dr. Miller?
This is me now? Okay.
Sure.
Thanks, Tara and Christina. So who do we serve at Monarch? And Tara sort of implied that we serve a transitional population from the hospital out to the community. And so we essentially, for the most part, serve moms and babies from the Ottawa Hospital as part of their discharge planning. So, in planning for discharge from hospital post discharge, generally 1 sleep for a vaginal birth and 2 for a cesarean birth. Those patients would be discharged actually to Monarch Center as their postpartum follow-up. They always get referred as a dyad. So we very rarely will see a mom alone or a baby alone. I mean, there are exceptions to that rule. Babies in NICU still, some certain specific circumstances where we would split the dyad, but generally we see them as a dyad. We don't only take referrals from the hospital, we also take referrals from the community as well. So, and we've sort of expanded this over time just through need. We take community referrals from midwifery frequently for evaluation of jaundice, weight loss, some more complex breastfeeding support that they may be requesting. We take referrals from family physicians in the community as well. Maybe a baby ends up in your clinic immediately postpartum and you're concerned about jaundice or weight loss, breastfeeding issues. We'll do that. OB as well will refer to us from the community from patients who have been discharged from hospital. And pediatrics will as well for jaundice. OB is often the maternal side, obviously. So wound problems, breastfeeding problems, breast issues that they'll sometimes refer to us as well. As Tara said, we also serve OSNI, which is the agency that manages the patients from Nunavut, their health needs while in Ottawa. And so that we just are there to facilitate transitions again from hospital, but also back up to Nunavut. Sometimes these are a little more complex discharges for us when we're trying to decide if, it's one thing to decide if a baby is okay to be discharged to Orleans. It's a different thing when they're being discharged to, somewhere up close to the Arctic Circle in a fly-in community. So that's a sort of an interesting transition that we've had to maintain. We're doing CHEO referrals as well. This is sort of jaundice discharges. A lot of babies from Emerge, for example, who may be seen with jaundice but need follow-up, and just to have them not come back into the emergency setting. We have a newer program with MFM, so maternal fetal medicine, whereby a lot of more complex patients there was danger that they were being lost to follow-up post-discharge from hospital, that we were helping to manage some of those discharges as well. And then lastly, public health nurses from Ottawa Public Health. This was in a way more active pre-pandemic when the public health clinics were more active. We would often see patients, mother-baby dyads, referred from breastfeeding clinics, either for concern about weight loss, jaundice, etc. So those are some of the people that we serve. This is back to you, HR.
Yep. So what do we do? So as Dr. Miller mentioned, we always take care of the dyad when they come through the door. So a lot of times families are under the impression, oh, I'm just here for a jaundice check. You're never here just for a jaundice check. We always take care of the whole mom and baby because, of course, they work together in helping each other out. So every mom gets a full postpartum check. So her blood pressure checked. We check on her lochia, her pain management, her breasts, her output, and of course, her extremities. We do have patient-specific follow-up. So, of course, a lot of moms who were followed for preeclampsia or gestational diabetes are followed again afterwards, and wound management, mainly with cesarean sections. All moms get breastfeeding support if they need or require it, and that includes checking for tongue ties, checking their nipple health, their breast health, pain, of course, comfort with breastfeeding, mental health screening. So of course we review the risk factors with every mom, make sure she's aware of what would be considered the normal baby blues versus a more serious postpartum mental health disorder. So we check on that, and then we can refer accordingly if needed. And everything that happens within the Monarch Center is sent to their primary care provider. Some families don't have a primary care provider, so we do have a list of family doctors in the community who have agreed to take on new babies into their practice, and some of them moms as well. So we have a list of family doctors and pediatricians. So of course the babies also get a full assessment by the physician, check their heart and lungs and their hips, checking for murmurs. It's just a basic full assessment. We check every baby's weight at every single visit. And of course we provide any feeding support, whether they're breastfeeding, pumping, formula feeding, or all three. Jaundice assessment for all newborns who are under 2 weeks of age. So again, these are babies directly affiliated with the Ottawa Hospital. So we have direct contact with the pediatricians and neonatologists at the Ottawa Hospital if ever we have any concerns or babies need to be readmitted. We will assess for tongue ties for all babies. Any baby who's less than a month old and it's interfering with feeding, of course, we can release those as well. And again, we're linking to the primary care providers and assisting them finding one if the family doesn't have one. So this again is transitional care. We don't do long-term care. We don't have a vaccination program. So most of the time these babies are discharged within 6 weeks, a lot of times sooner because we want to get them back to their primary care provider, making sure that they have good long-term breastfeeding support if they need or want it, and good follow-up for weight checks as needed. Go ahead, Dr. Miller.
Okay, so the question is, how has Monarch adapted to the pandemic? And I think that's I mean, how have we all adapted? It's an interesting topic. We thought we'd sort of give a little overview of how things were before the pandemic at Monarch. So at the pre-pandemic, we probably saw about half the discharges from the Ottawa Hospital, and the other half were, most went into very secure follow-up with practitioners who were comfortable with early newborns, so 1 to 2 day olds, who had practices that were available 5 days a week at a moment's notice. And so we at the hospital, sorry. So that was the other 50%, and then some of the 50% were babies from the NICU and things like that were just not in our scope of practice. Before the pandemic, we also accepted tongue tie releases from the community, and we were able to accommodate them easily in the same week. We accepted lots of breastfeeding referrals as well from the community, and we had quite a few transitional families from Nunavut pre-pandemic. That was a lot of what we did, and that was sort of the bulk of our work was hospital-based stuff, about half the stuff in the hospital, and then these sort of a array of community-based stuff. So post-pandemic, or during pandemic, things have really changed at Monarch. And we'll have some slides later that kind of show the numbers as well. Now we're getting about 80% of the discharges from hospital. And a big part of that initially actually was because all of the physicians' offices shut down in the immediate part of the pandemic. So it was very hard to get in for an in-person visit at a primary provider, whether it be a family doc or a pediatrician. And so there was, it was a bit of a crisis actually initially in trying to find secure follow-up for a lot of these patients on discharge from hospital. And so we started seeing an increase in direct discharges to Monarch. The numbers probably haven't backed off that much since people have started to open up their practices, in part because a lot of people just don't run everyday offices for in-person visits. And of course, in newborn care, in the immediate post-discharge period, you sort of need to be able to you can't do a phone visit, virtual visit for a 3-day-old. And so we probably, even though most doctors' offices are starting to open up for in-person care, we're probably still seeing that increased number of discharges from the hospital just for that. It's become easier for us to discharge them from Monarch into the community, but the discharge from hospital to Monarchs has remained high even since the offices have opened up. We do still do tongue tie referrals from the community, but less so than before, just because it's harder for us to accommodate them just with the numbers. We feel our main commitment is to discharge planning and transitional care planning from hospital and institutional care to community care. So we're doing a little bit less of that. I know that's frustrating to some of you who are trying to get in with us for those. We've had to add quite a bit of admin time, and I think a lot of people have out there, just for screening and administrative duties within, PPE within the clinic. We've moved a lot of our admin work has actually moved to virtual admins that we use at home. So we have a lot of our 6 care coordinators. We always have an in-office care coordinator, but we actually also have one working from home every day in parallel with the ones who are working at the 2 clinics. And those are the ones who are building the charts, doing the screening. All that's happening actually from someone at home. Some of them aren't even in Ottawa. But we have VoIP phone system and sort of soft phone. So it looks like they're calling you directly from Monarch, but they're actually at a number of different locations. And we found that's worked out really well for us in screening the numbers of people and doing it safely and not having to have all that activity happening in the space. We've obviously had to increase nursing time. We've, like everyone else, we've had to add PPE. We've bought new equipment, automatic blood pressure machines, everything that we've been able to try to do in order to reduce contact and sort of improve our efficiencies within the clinic. And then the other one, and the last couple of bullets here, this of course is upsetting to a lot of people, and we've, I think people are understanding of it, but we're not as happy. We're unhappy about it just like everyone, but we feel it's important that we have only the mom and baby inside the clinic. So the partners and support people are asked to wait in the car. And it's worked well. I mean, there's been just a little bit of pushback in certain cases and sort of special circumstances. But for the most part, I think people are understanding of that. I think it's like that in most health organizations. So that's a big change that we've had to make. One of the things that we're proud of is that we've started to do some virtual breastfeeding support through one of our physicians who now works exclusively virtually in the community. And that's Dr. Joss Anderson, who many of you might know already. She's an IBCLC, a family physician who is a member of the American Academy of Breastfeeding Medicine as well. And so she's able to provide virtual breastfeeding support for those of our patients who are sort of finished with our in-office care, but still need some ongoing support, maybe for pumping plans or just ongoing, just virtual problem solving on the breastfeeding. And they're able to do that virtually without having to go out, and they can do it with Dr. Anderson. So those are sort of the changes that we have made to adapt to the pandemic, probably similar to many that others have made. But that's sort of a little summary of what we've done. I don't know if there's another one. This is so I think I might have talked about this stuff. Community breastfeeding.
It's
we talked
Morris
about that.
Dr. Anderson. Yeah.
Yeah. So this is sort of a summary of what she's doing. The other thing that she does actually is a big part of what she does is she is doing she's doing the screening of our care coordinators screen all of the patients for sort of febrile respiratory illness screening, and Dr. Anderson will sort of take the ones that they screen positive. So our care coordinators identify someone who may be a positive, they send them to her, and then she sort of will call the patient directly and have sort of a physician evaluation of that patient to make sure they are able to come to what we call regular Monarch versus having to go to C-19, which Dr. Moores will talk about shortly. So that's sort of the transition between our, the community-based Monarch with the hospital-based C-19 Monarch is through, Dr. Anderson makes that kind of final determination as well with the patients over the phone. So you want to talk about this one, Tara?
Sure. So basically the families are screened before their visit over the phone the night before, and again when they reach our doors. So if they screen positive, we have a partnership with the Ottawa Hospital, our new Monarch C-19 clinic, which Dr. Daisy Moores and Claudia will talk about. It's a direct referral to the C-19 clinic and through the Ottawa Hospital General Campus, and then a referral is sent from us to C-19, and then the hospital calls the family with their appointment time. But I will let the logistics end of that go to Dr. Moores and Claudia. We just want to show you our numbers.
So this just sort of reflects what's happened during the pandemic and sort of the need for secure follow-up in the community. This is patient visits. 2019 pre-pandemic, we had 14,300 visits, and in 2020, 18,366. So we had a significant jump, probably in the 30% range during the pandemic, and that's splitting mother and baby. So that's individual visits during the pandemic. And then we broke it down by quarter as well. This kind of tells the same story. These are dyads actually. So Q4, almost 2,500 dyads in Q4 of 2020. So the last sort of data that we have there. So, and that's it. That was all. If anyone has any questions, we're happy to answer them.
Excellent. So I'd like to invite the participants to use the question and answer box, and you can put your questions in there and we will answer them as they come.
So I'm just looking here, Catherine, are there any questions right now?
Not as of now, but they've just maybe started to see the Q&A, so I'm giving them time.
Okay. Yeah, and I think the Monarch has attracted a lot of attention provincially. Certainly when the Provincial Council for Maternal Child Health was developing the postnatal standards, Monarch was definitely identified as a fantastic example of mother-baby dyad care. You heard Tara and Dr. Miller talking about the dyad together. It's not just one or the other, it's looking at both of them together and addressing their unique needs at one location with very skilled interprofessionals working together. So the whole model has been really phenomenal. And then the way that you've been able to pivot during the pandemic has been exceptionally beneficial for the community as well. It just speaks to that relationship, that very strong relationship with the Ottawa Hospital, which would be the largest birthing center here in this part of the region. Actually, the whole region is the largest hospital, for sure, the Ottawa Hospital. But just to manage the quantity of patient flow is really quite impressive. So congratulations to all of you who are involved in making that happen.
So we do have one question that came into the chat box. Do you accept referrals from other hospital, example, Montfort?
It depends. We don't accept transition care from Montfort, and there's logistical reasons for that, and there's also just practices that have been set up. The Montfort has, of course, their own model for care postpartum, in terms of monitoring both jaundice and weight loss through their pediatric team there, as well as I think they have breastfeeding support as well postpartum. We sometimes have patients who are born at the Montfort end up in Monarch, but they typically are ones that have come through community-based referral. And again, during the pandemic, those numbers have gone down because they pre-pandemic, it was like tongue tie releases and things like that. Sometimes we'd see Montfort babies. There's a bit of a practical reason for it as well, in that if it's a jaundice referral, we do all our jaundice testing through the Ottawa Hospital. So all our serum bilirubin tests are through the Ottawa Hospital, and the samples have to come from a baby that has a MRN from the Ottawa Hospital. So it seems like, kind of a silly reason not to be able to do it. It's a very technical reason, but we can't process those samples on patients who aren't actually patients of the Ottawa Hospital. We do most of our bilirubins initially actually through transcutaneous bili testing, but using the provincial standards and the quality-based, the QBP that's been produced by the province, we use the algorithm that includes converting to a serum bilirubin if your transcutaneous bilirubin is within 50 micromoles per liter of the phototherapy line. So we know that even though we're doing a non-invasive bili, we may end up having to convert it into an invasive bilirubin test, and therefore we need to have an Ottawa Hospital baby in order to do that. So that's the short and the long answer.
Thank you so much.
Okay.
You can cut me off, Christina, but I'll continue with the questions that are coming in. So was Monarch model a clinical necessity for maternal child following changes into the public health system in Ottawa?
I think it reflected a number of changes that had happened over time, and a number of gaps in care that we had identified. And some of them were obvious. The length of stays were shortening at the hospital. So, vaginal birth was going from 2 days down to 1, C birth 3 days down to 2. And so there was a need to identify how to safely transition those babies and those mothers out into the community. But it also reflected what was available in the community for follow-up. A lot of patients did not have primary providers in the community who were able to do immediate newborn follow-up, either because they just didn't have a pediatrician or a GP, or they didn't have one who was willing to or able to provide care sort of at a moment's notice to that brand newborn. And some who just weren't comfortable with doing 1-day-olds who were jaundiced and losing weight and having breastfeeding problems. So there was a need based on a change in practice, a change in availability of primary providers, and a huge gap between need for primary providers and supply of primary providers in Ottawa, and also just the importance of following the new provincial bilirubin guidelines, and there was an identification that needed to be appropriately managed as well, which wasn't necessarily happening. There was a gap in care there where we were wanting to identify that babies ending up in the emergency department with either jaundice or dehydration, and so I think it was all of that together that we identified that kind of led to the creation of Monarch.
Thank you so much. I think we will take one more question and then we will move to the next presenter. So the next question was how many weeks, I think it's number, I think I'm not reading right. How many dyads do you continue to see at the Monarch right now per week, average?
Oh, well, we saw, I think the last graphic showed 2,500 in the last quarter. So 13 weeks and a quarter, so about 200 dyads a week, approximately.
Okay,
I wonder
sorry.
if the question is for how many weeks after, like what's the longest duration that you would be seeing a baby within
that,
Monarch?
That makes more sense. we always say we'll go max 6 weeks. We don't want to go beyond that because, like as Tara said in the presentation, we don't have a vaccine program. We also don't want to get involved in seeing sick kids with runny noses and rashes and diarrhea and stuff like that. We don't really want to introduce that element of baby care into our clinic, seeing as we have these vulnerable 1 and 2 and 3 day old babies in the clinic. And also, importantly, we want the babies to be back at their regular provider. We want to normalize things as much as we can. I mean, we're there for a gap in care. We're there to transition them properly into the community, but we want them back with their family doctors. We want them back with their pediatricians as well. And so, yes, we'll keep them for 6 weeks, and there are some that we have to for a variety of reasons. But usually, most of the babies are here with us for anywhere between 4 and 10 days, I'd say would be the kind of average. Sometimes up to a couple weeks, but rarely. Yeah.
Thank you so much. So keep putting your questions in the chat box. We are going to move on to our other speakers so that everyone has enough time to share the information that they've prepared. So at this time, we're going to be talking very specifically about the Monarch C-19 clinic that was designed specifically for patients during the pandemic. And so we have Claudia Smith, who is a registered nurse and clinical manager of 8 East, which is the combined care unit. And she's also responsible for lactation services and the Monarch C-19 clinic at the Ottawa Hospital. And with her is Dr. Daisy Moores, who is the medical co-lead of the Monarch C-19 clinic. She's also the head of the Division of Maternal and Newborn Care at the Ottawa Hospital, and she's a family physician practicing low-risk obstetrics and newborn care. So Daisy and Claudia, tell us about C-19.
Thanks, Christina, and thank you so much again for inviting us to be part of this webinar. It was neat to be part of the Postnatal Care Taskforce, and then this is a lovely continuation of sharing of the information that we gathered in that time. So Claudia and I are going to go over the C-19 clinic with you, and Dave and Tara were just as involved at the inception and the setting up of this. And I thought we would start off our presentation with all throwing our memories way back to March of 2020, which is not quite a year, but feels like a long time ago, for me at least. And as everything was sort of imploding in terms of the pandemic, like many other institutions and organizations, the Ottawa Hospital was trying to figure out how we were going to manage our programs and our services, especially with regards to how to take care of families that were either COVID positive or COVID suspect. And we have to remember how the different phases of the pandemic have rolled. And remember back to March when it took like 10 days to get a swab result. And so there was differences in what was perceived to be the need then and what has changed over time. And so when we were setting up this program, and it started with a number of conference calls between many of us at the hospital that had a stake in this, trying to figure out what we were going to do to take care of these families. Because as Dave and Tara have said, the Monarch Center is a community-based clinic. It doesn't have the ability to see families that are COVID positive, for example. And the real reasons for this were a lack of PPE, and that was a big issue at the beginning. And also of cleaning. We used to think that the cleaning was much more important than we know it is. Still important now, but not to that same degree. And then the other really important difference, of course, is that the Monarch Center is set up as the postpartum follow-up care at the Ottawa Hospital. And unlike other hospitals, like the Montfort that Dave mentioned, there is no in-hospital newborn follow-up program. So there's no easy place to say, this family can go at the end of this clinic to be seen. We don't have that ability at TOH because of the volume, and because the volume is accommodated through the wonderful Monarch Center. So when we were trying to figure out what we were going to do with these families that were either positive or suspect, we thought about how we could care for them still well, yet not put any of the care providers at risk. And we were worried about not having the ability to follow up these families and have them have the support. that they would need it, that they would need in this time. The suspect part is really important as well, because we, as Dave and Tara spoke about, the families are screened before going to Monarch. And so if anybody meets criteria for needing to be swabbed, needing to be isolated by Ottawa Public Health criteria, then they also can't be part of a regular community-based clinic like Monarch and all other community-based clinics have had to do. So very quickly, at the very end of March, the Ottawa Hospital and the Monarch Centre and those of us involved in both places put our heads together to try and address this issue. And over the course of a couple of quick meetings, created the Monarch C-19 clinic. Just go to the next slide there, Christina. So the partners are listed here. So the newborn care falls under the Department of Obstetrics and Gynecology and Newborn Care at TOH, which is who Claudia and I work for. The Monarch Center, as we know about, and then also the Department of Family Medicine, Division of Maternal and Newborn Care, which is where Dave and I are members of as well. So that's all the family doctors that do obstetrics and newborn care at the hospital. And this was a really good combination in order to provide this service, because as family doctors, we can easily take care of both moms and babies and not have to have any more care providers involved in a family that's COVID positive, where you don't want to have as much exposure. We can go to the next slide, and then Claudia is going to take over.
This is about where I was involved in the inception as well. So we had to move really quickly. I got a call, I think it was a Thursday afternoon at 3:30, and they said, we want to open the clinic next Wednesday. And so we basically had to hightail it and figure out where we were going to put this clinic. So it opened on April 6th officially. And I think, like I said, there were some initial discussions with the physicians and with our director. And then from the time we thought about having this clinic to actually opening the doors, it was 3 weeks. So it involved many partners that we had to include within the hospital itself, as you can imagine. So our infection control team were very involved at this point, because we were asking to bring in either positive or suspect moms and babies into a hospital where we're trying to keep positive people out, essentially, right, by reducing the amounts of people going through the hospital. We had to involve our screeners, so our door screening at the front of the entrance, because we would be walking these patients through their screening stations. We had to involve housekeeping, of course, because between every single visit, we had to wash and thoroughly clean the rooms and supplies and equipment. Our supply chain team was involved as well, just to make sure we had everything that we needed for all of our appointments. The ITIS team had to basically create a new clinic, as well as our EPIC team. So EPIC is our electronic documentation, and so we needed to have a record of these visits and a way for to have some follow-up after they had come to our clinic. And our electronic record needed to be created for this clinic as well. So that became, we had to have all these people involved in the inception. So it was definitely a team effort. We can go to the next slide. So what it looked like initially, with trying to think of a way to get patients into the hospital without possibly contaminating other patients that were already there, we had to try and find something that was as close to the entrance as possible. We didn't have a clinic that we could access from the exterior of the hospital without kind of crossing some major areas. So we ended up setting up in the pre-anesthetic care unit, which luckily enough was not being used at the time, because the ORs had kind of shut down for a little period of a period of time. So we had a clerk there at all times, a nurse, an escort that would escort the patients back and forth. We had a physician there and a housekeeper, and we ran an 8-hour-a-day clinic. We didn't necessarily have enough patients to cover the 8 hours, but we had all those staff available should we need to run a full clinic. So initially, we weren't sure what our numbers were going to look like. And the staff that we did obtain for that clinic were repurposed from other programs. So with the ORs closing and with parts of the Riverside closing, we were able to utilize some of the nurses and clerks from those departments and run our department essentially without taking staff from our units that they were, where they were needed. So as time went on, and the hospital kind of started to slowly reopen to our operating rooms and surgeries, we had to think of a new location because the PAU was going to be used again. So we thought about how we would do this and where we could possibly run it. And because our numbers were fairly low, we realized that it was something that could have been done in off hours. So we have now set up in the maternal fetal medicine clinic. So once the maternal fetal medicine clinic closes at 5 o'clock, it becomes the Monarch C-19 clinic, where we can see all our patients that are either COVID positive or COVID suspect. The nurses that staff that unit now are my nurses on 8 East and my clerks, essentially, who do the bookings, and a family physician from the team that also works at Monarch. So So the way the clinic works, so the patients are pre-booked. So what happens is we get a referral from either the civic campus or even our own campus. We make our referrals so that we can keep track. They're pre-booked in our booking system, and they're given an appointment time and a date. The patients come with the baby. So like Monarch, it's just the mom and baby that come in, and they wait outside the hospital, and they call up to our unit to be allowed into the hospital. So when they need to come in, either the physician or the nurse, whoever's available, goes down in full PPE and escorts the patient directly to the clinic room, where we put them in and we bypass screening altogether. So they don't need to get involved with that piece. In that room, the baby can be weighed. We can do a bilirubin blood work. We can do, other types of newborn care that they would need, and as well for mom. So we have the clinic set up so that mom can also have some care done. And as we would do for any of these visits that would happen at the regular Monarch. We can also do COVID swabs. So if we have a mom that has gone to Monarch and has failed the febrile respiratory illness screening, and they need to determine whether or not this mom could potentially have COVID, we can do the swabs directly there. So they don't need to go to a testing center in Ottawa. They can be done right in the hospital. We can also do some feeding assessments. We don't provide LC support like the regular Monarch does, but the nurse or the patients and babies that do need some LC support still have access to Dr. Anderson. So those are just done as a separate referral. And once the visit is done, so once every concern that's been addressed, the mom and baby are escorted directly back to the front door by either the physician or the nurse, whoever's available once again, and in full PPE, and they're brought directly to their vehicle. So there's no contact between these COVID positive or suspect patients and other patients in the hospital. All rebookings are handled by the clinics clerks, so my clerks essentially. So what happens is, say the family needs to be seen once again for a second visit, the physician will just notify my clerk and they will rebook them for a follow-up appointment, and we can continue to see them until they are either deemed negative by swab, and they can then go to regular Monarch. So if they're no longer symptomatic and they're negative, or we continue to see them until they no longer need us and can be seen in the community. So the electronic record that we use is Epic. So that's also the same. So we were able to redesign our template from the previous Monarch clinic. And then our referral was essentially the same as what the Monarch referral was. We just made a few tweaks and removed the breastfeeding portion of the referral because we weren't able to provide that. So yes, and I've already covered that piece. And yeah, so once everything's okay, they can be transferred either back to Monarch, to their own family physicians or pediatricians. And after the visits, the records are scanned electronically so that we have we can ensure that we have continuity of care. So we always have the most up-to-date information. So whether it's the most recent bilirubin levels, or whether that's just the note from the physician, everything gets screened in, so we know where the patients are at. So we also have had the opportunity and capacity to see a couple antenatal patients who needed visits. So while they were on isolation, we've tried to focus that on the last 4 weeks of pregnancy. So as they're kind of getting closer to the end of their pregnancy, we haven't had to see too many of those, but we are able to. Usually what happens is it's an OB consultation with the family provider so that they at least have an idea of what's going on with that patient. And they send us any antenatal information that we would need to know in order to conduct the visit. If a maternal medical issue requires specialty care, we can also liaise with the OB/GYN that's on call at the Ottawa Hospital. So it just makes it simple for them to, if there's anything that the family practitioners can't do that, the OBGYN can come in at that point, and we have all the PPE necessary to see those patients. We also have had to open a bit of a COVID nursery. So we have a room designated for readmissions should we have to readmit babies. We provide the nursing care for that if a mom cannot find someone to care for the baby. So we've used the term clean here, but it's not that they're dirty. It's just that they are not COVID positive or COVID suspect family members or friends that they feel comfortable looking after their baby while they're in the hospital. So we would not readmit a mom who is suspect at this point. It would just be someone who is either in their family that hasn't been around them in the last 2 weeks, and that they can look after the baby while they're here. Or if they are not able to find that, then one of my nurses will be in the nursery with the baby at all times.
Great. So some of the challenges that we encountered along the way, because it was a brand new thrown together clinic, was that using some of the reassigned staff meant that we had to train and retrain a lot. Our original clerks were all from the Eye Institute. So there was a lot of differences in knowledge and background, although they were amazing with Epic, like far more amazing than I ever know. So lots of retraining, which is good, but also a bit labor intensive. It was really hard to find physicians to discharge patients to if they didn't have a physician already. And we had a list of community-based pediatricians that had stepped up to help with baby care if someone didn't have a care provider, which was excellent. The volume varied, as Claudia alluded to, so planning was very hard. We could have everything from 2 people, and then when there was an outbreak on one of the postpartum units at the Ottawa Hospital, we had 10 people every day, which was quite a lot for this model of a clinic. So our planning was challenging because of that. Running a clinic that's occasionally used in the evenings means a lot of continual work, mostly on Claudia's end, of keeping track of supplies and logistics. And Claudia and I do a lot of messaging back and forth, troubleshooting things that come up as they do. And then the other challenge is that, as we all know, over the last year, Ottawa Public Health and our internal IPAC guidelines have shifted quite a bit, especially at the beginning, but still do. And so we have to keep making sure we follow these carefully so that we're planning properly for families and giving them the right information in terms of their follow-up and what they're able to do and not do. Just the next slide there, Christina. So we've had a lot of feedback from families, and these are some of the things that people have said to us. And the main themes are very much along the lines of being incredibly grateful to have somewhere that they can go with their baby in a time when nobody else wants them anywhere. When you're COVID positive, you're supposed to stay home and do nothing else, which when you have a 2-day-old is very scary. So that first clinic quote was a very frequent one that we heard. There was also a lot of counseling and teaching that we did along the way about COVID and about COVID when you have a newborn and with your family and how to keep everybody safe and healthy. And so we and the nurses do a lot of talking to families about how to do this and reassuring them a lot about what they can do and how much control they do have in this situation. And then the last piece is lactation support. So we do have access to virtual lactation support, but the doctors that work in this clinic spend a lot of time doing this, so we can do a fair bit of this piece on our own. And the nurses that work with Claudia that come over and do the clinic with us as well, they're mother baby unit nurses. They have a lot of these breastfeeding skills too. So the patients have gotten far more lactation support than many of them thought that they would need. So the question that we get asked a lot is, are we busy? And I will say that the volume varies along with the pandemic. And it has really been this has been like a little microcosm of what is the pandemic in the city. So when the case counts are higher, we have more patients. When school's in, we have more patients just because of the sick kids who then the families failed the screening for. When there's a lockdown on, we have fewer patients. Christmas time, we got all the Christmas visitors that got COVID by accidentally letting someone to come over and see their new babies who had COVID. So we generally have not had tons, which is good. We're really happy about that, actually, because generally families are staying close to home before their due dates, as we advise them to, and are staying healthy. And we certainly wanted to really point out that we have seen in our patients a reflection of the patterns that the larger community is seeing in terms of who gets COVID infections. So we have a much higher proportion of new immigrants, of essential community-based workers, families, those living in large households. We had one woman a little while ago who was one of 11 adults in her home. And certainly that has very much rung true in our clinic as well. And we also do have a strategic plan in place with the Monarch Center should we have, say, an outbreak at a TOH site, or there's something that happens in the community that means that we have to expand quickly. And we've been very good at reinventing ourselves twice already and can do so again if we need to accommodate more patients. So some lessons learned for our last few seconds here. The pandemic response has required a lot of flexibility, teamwork, and a lot of adapting, which a lot of us have really enjoyed, truthfully. We didn't want to have done this, but that's been quite neat. Using an existing model like the Monarch Center and care providers, the nurses and the physicians that work there, that regularly could provide this care has made it very straightforward, because the clinical care part, other than adapting it to COVID, has been straightforward. It's the actual delivery that's been more complicated. We have certainly reaffirmed that we work with a very devoted, caring, and hardworking group of people, and have been constantly amazed through this time how resilient families are and how well they have coped with challenges in what is already a very challenging time. We, at the beginning, got a lot of press. I think it was a quiet news day when Dave and I got to be on the front page of the Citizen when we opened the clinic. And then we also had a couple of CTV spots, which were great to do because it was in the early part of the pandemic when there needed to be a lot of reassurance to the community that care was available and that they would always be cared for and there was safe care in the hospital. So we were very happy, although nervous, but very happy to do these TV spots and news articles to be able to really provide that information and reassurance about what we were doing. That's it.
Yeah, that's awesome. We were so proud of, again, the good work and to see it showcased. You know, it was evolving constantly, right? That was the early phase one of the pandemic. It was like, okay, you know, minute to minute, hour to hour, it was just shifting. So yeah, that was pretty impressive. Again, you know, how quickly that was pulled together, you know, with so many people and a lot of work to shape that. So for the questions, do we have anything in the Q&A box, Catherine?
No, we don't at the moment.
We have a quiet group today. That's okay. And what's neat about this model, you know, we're talking about family physicians and nurses and lactation consultants. But even at the C-19, it's the mother-baby nurses, right, who do have a lot of lactation skill and support that they can provide to families. So it was kind of neat as you were looking at different care providers who's available to be providing service and support during this time. But yeah, what does that mean in terms of training? Like, you realize how specialized our care providers are, right? We can't just replace a care provider in this specialty. There's quite a bit to know. So that's amazing. I saw little pops. Was that maybe that was your message, Catherine, there?
There was just one question that came up.
Okay.
What would you say your lessons learned are for implementing something so promptly in order to meet this urgent need?
Yeah, maybe Claudia and I can take a stab at that. So I think it helped that it was a pandemic and everybody was jumping to address an urgent need. We are so fortunate in our group to work with a really caring, motivated, hardworking number of people. And so what we did was gather together those folks who were going to be able to jump fast and pull this together. I remember leaving on a Friday, Claudia, and you had hours of setup to do still, and you did it, and not everybody would, right? And so those pulling together people who are willing to put in that time so that we can take really good care of people was the main thing. And also having the huge institutional support from both TOH and Monarch to put these resources to this problem. And so the leadership of the Department of Obstetrics and OB and Newborn Care was really, really key to this. And their support was why this was able to happen, as well as from Dave and Tara's end of Monarch. Do you want to add anything to that, Claudia?
Yeah, the hospital was kind of moving quickly already. And so from a leadership perspective within the hospital, so when I'm looking at all the allied health that we needed to involve and all the other services that we needed to involve, the managers were also very responsive. And so when we would ask for something, it would be done almost immediately. There was no wait times really, just because we were all aware of the crunch that was there. So there wasn't a lot of there wasn't a lot of barriers when it came to that kind of thing. So that really helped, having the fact that it was in such a large institution that already had people that were already moving at an extremely fast pace.
Perfect. Well, we are going to still take the questions. And if you think of a question, we can connect with you if we run out of time, because we're quickly at our 1 hour mark here. But we do have a special addition to this webinar series. So I do want to introduce Dr. Michelle Ward. So here, let me see. Dr. Michelle Ward is a pediatrician and division head of children and youth protection at the CHIO. And so Michelle's going to be raising an important issue that has come up through the pandemic. Dr. Ward is an associate professor at the University of Ottawa and president of Child and Youth Maltreatment section of the Canadian Pediatric Society. So Dr. Ward, do you want to take a couple minutes to talk to us about an important issue that you've identified?
Great. Are you seeing full view there?
Looks good, thanks.
Perfect, great. Well, thank you very much. And I will try to just give the key messages so that people can get out on time or as close to as possible. So yes, hi, I'm a pediatrician. I work at CHIO. I work in the area of child maltreatment, but I'm a general pediatrician and have worked in emerges, CTU for many years, and outpatient locums, a variety of things. I now do exclusively child maltreatment work, and essentially we have a team, multidisciplinary team at CHIO that patients are referred to where there is some kind of health concern that needs assessment related to abuse or neglect. We do take referrals both from physicians and non-physicians. We get a lot of our referrals through child welfare agencies, but also sometimes teachers, police, and other folks. So what I wanted to talk about today was just very briefly about what we're seeing in child maltreatment, but also specifically what we're seeing in traumatic head injuries in infants. So what's the issue? Overall, what we've seen in the pandemic, and you may have seen this in the news as well, is that we're seeing a decreased number of reports of child maltreatment, abuse, and neglect. That's from the child welfare perspective, like the Children's Aid Society, as well as police service and the hospital. And so at the beginning of the pandemic, we all became very concerned because we all went really quiet. And we know that that doesn't mean that child abuse has been cured by the pandemic. What it means, we think, is that it's just not being identified. The most common referent to a child welfare agency is a teacher. And so while kids were not in school and while they were in virtual school, the same kind of connections between kids and their teachers and hospital staff were not happening. So disclosures were not happening. Teachers were maybe not identifying or asking about things because they just didn't have that kind of opportunity. However, what we've noticed over the last few months, really since the beginning of late summer or beginning of the fall, is a real spike in injuries, significant serious injuries to infants. So by that I mean serious head injuries and fractures to little babies. They're typically 2, 3, 4 months old are the infants that we're seeing. So we thought anecdotally we were seeing this, and then quickly just pulled our numbers for that time period from September to January. when we began to raise the issue, and saw that in the prior year we'd seen 8, and in the current year we've seen 20. And I'm sorry to say that this is actually continuing. We have several children in hospital right at the moment as well. So this pattern does seem to be continuing. To give you some context, we were part of a Canadian study about 10 years ago that looked at head injuries, specifically in infants from child maltreatment, and there are about 70 to 80 confirmed cases per year in Canada. So we are seeing way above what we would normally see. When I speak with my colleagues across the country, the areas that seem to be having more isolation are seeing the same patterns as well, versus, for example, my colleagues on the East Coast are not seeing this kind of pattern. So we do think it has to do with the social isolation and fewer supports. So what has happened? CHEO and Ottawa Public Health and Children's Aid Society of Ottawa very quickly got together and put together a public service announcement that, I'm sorry to say, is my face and me talking on a very pale looking day. So if you've seen it, you'll have seen that. But it was very effective in raising interest amongst the media, and then it became covered nationally by CTV, Global, CBC, and print media like the Toronto Star. So for a few days, it was sort of all over the media. The difficulty has been that other centers have either not been able to collate their data, or for various reasons have not been willing to release their data. So in order to keep something on the radar, you do have to have that data. But, and I'm going to say thank you at the end, in particular to Louise Gilbert at Public Health, who very quickly mobilized to do a number of things. So for example, being on this webinar, linking with professional networks, and lots of social media posting that generated a lot of interesting discussion. As well, there's been some direct communication with parents of children less than a year. So PHNs now have all been asked to discuss with parents specific content about what to do when they get frustrated, not if they get frustrated, because as a parent of 3 and all the advantages that a parent can be provided, I know as well as individually, as well as working with lots of families, that we all have our moments of frustration. So really giving that messaging that we're not just talking about high-risk families or families that don't look like ours. This is really a message that every parent needs to hear. And this is not stratified by socioeconomic status or by educational status. We unfortunately see injuries to young children from people of all walks of life. The baby helpline is giving specific information, and new parents are also getting an additional handout that is based on a prior piece of information, brochure essentially from CHEO, that talks about crying in infants, ways to soothe them, what to expect, and how to reach out for help if needed. OPH has also put together a list of resources, and there's a new postpartum depression tab on the mental health page for OPH. And I was just involved in a conversation late this afternoon with other partners around the region to try and look at what else can we implement, and in particular for families that are looking for ways to connect, like early years centers, breastfeeding clinics, anywhere else that new parents are. So trying to get that message out wherever we can. I think we really do need to think about this as a problem of isolation, and at the same time that we know from the literature that there's some very specific messaging that needs to be given in order to try and improve things. So I think all of you are integral to this, because you are in places where families intersect with various systems, and you are also people who they trust. And so that's what we really need, is to build on those relationships to share these sensitive topics and sensitive pieces of information. So just a reminder that all of these are preventable injuries, and they can have lifelong devastating consequences. The literature suggests that there are a few key things for prevention. And I will say that it's a really hard topic to study. How do you prevent early childhood injuries from maltreatment? Because fortunately, they're relatively rare in Canada. Previous data shows 17 per 100,000. So it's a low number to begin with, and then we're trying to decrease that further. So it's really hard to study, but these are the kinds of things that studies have borne out in terms of being helpful. So be very specific. You need to talk about crying, what crying is, that it starts at 2 or 3 weeks, that it peaks at 6 to 8 weeks, that it's typically reducing by 3 months of age, and that they may not be able to soothe it, and that is normal and is not a failure on the parent's part. That they will sometimes feel frustrated, and that is normal. We always used to talk about never shake your baby, and that is a message that needs to be articulated explicitly, but we also need to say always be gentle with your baby. So it's not just shaking we're talking about. There's many other things that happen to babies, and so if we over rely on that one message, we find that people sort of don't see the other pieces of that. So it's the always be gentle. Don't put anything over your baby to try to make them be more quiet. Just always be gentle. I think parents mostly do know that a brief moment of frustration can cause lifelong problems, but in studies still show that some people actually don't know that information. And then ask them to make a plan and contract if they can. So write it down with you. What am I going to do when I get, what can I do in my context with with the resources that I have? What am I going to do at that moment? Get them to write it down, ask them to stick it on their fridge, put it in their phone, whatever works for them. And if they can, just make a verbal contract. That particularly increases the feeling of responsibility for behavioral change when studies have looked at it. Give specific resources, and there are lots of great ones on the OPH website, as well as CHEO website and other places. Write it down and repeat. So the more times they hear this message, actually, the better. And then for all of us to think, where else in the system can this happen? So that is my quick plea, I think, so that my group hopefully starts to see a decrease in this. We're concerned at where this pattern is going. And I want to thank Louise Gilbert, who really jumped into action, connected with lots of people, and put some things in place really quickly. Also invited me to be here today. Claudia Smith from the Ottawa Hospital, who very quickly had the idea to get more pamphlets out as people were leaving hospital and have nurses connect right at that moment. And then CHEO, OPH, and CAS leadership for just taking this on quickly.
Yeah, thank you so much, Michelle. It's really important to have like the data to raise the alarm bells, and not just Ottawa, right? Like you're talking the outlying areas as well as who CHEO supports. So it's not an Ottawa issue,
Right.
It's an issue for everybody. And to be having these conversations with families proactively. I had a question about the contract. When would families write the contract? When they've had a time of frustration and they're talking to a care provider, just saying,
yeah, so the studies that have looked at this, essentially as you're giving educational material, even if it's just a signature on the educational material to say, this is what I'm going to do next time, and I'm signing my name to it, somehow makes it a different experience for the parents, we think. So it's just that extra step of having the explicit conversation, making it applicable to them. What are you going to do, when you feel some frustration, and having them put their name to it.
Perfect. Thank you so much. This is just the beginning of work on this, topic, but we're so thankful that last week Louise was able to join and share a similar message, and then today, thank you so much for joining our webinar. I'm going to share a picture here of the handout that you're talking about, and Catherine, if you could pop it in the chat as well, that would be great. So here's the picture of the CHEO understanding and coping with your baby's crying. So it's a two-sided handout and very practical tips in terms of, what to do when the baby's crying, and, why babies cry, and what steps you can take. So I think it is a good resource, and it seems like a lot of partners are sharing this.
If you go to the CHEO website and just type in crying in the search bar, that's what will pop up for you.
And we always like to promote Best Start Resource Center. So they have a really great booklet on 0 to 3 months. And again, previous work we've done over the years is families really don't understand newborn behavior. So even what's normal for sleeping and crying and, all these behaviors. So those resources from Best Start Resource Center are amazing as well, low literacy and available in different languages. So we can share that as well. So thank you very much, everybody. We're over our time, but we thought that that was a really important issue to bring to everybody's attention. Next week on Thursday, we're changing topics. We're going to be celebrating the year of the nurse and the midwife. I know we're late. The pandemic didn't allow us to celebrate and recognize this important acknowledgement, but we have Dr. Danielle McDonald, who's going to be celebrating the collaboration between nurses and midwives and experience from Nova Scotia. So we're very excited to have that webinar next week, and Catherine will pop the link into the chat to register. So thank you, everybody, for your attention, your engagement throughout the webinar series on postnatal care in a pandemic. Ariane will be sending out a link to the recorded session from last week as well as this week. So please feel free to share widely, and we'll be uploading some resources to our website. Thanks, everybody, and have a great night. And a special thanks to our amazing panelists and all the phenomenal work you've been doing for almost a year related to the pandemic response, and even before that, the Monarch Center and the leadership that you've shown in the region in terms of a different way to provide care that gives us that soft landing, that safety net to make sure that no family falls through the crack at that really important time. So kudos to everybody, and thank you, and have a good night.